Okay, guys, this is the back end of the respiratory chapter. So we're going to finish up the final bit of material you need before we take care of the midterm. So let's talk about how we breathe, what it is that initiates breathing. The respiratory center is in the medulla oblongata. Remember that that's the portion of the brainstem that lies below the pons and above the spinal cord. Inspiration is an active process in which the diaphragm receives its signal through the phrenic nerve, causing it to contract and flatten, and this increases the thoracic cavity space. This increase in the cavity volume causes the pressure outside the lungs to drop, and that creates a vacuum. And because the lungs tend to cling to the inner walls of the thoracic cavity, what happens is that in turn creates a vacuum in the lungs, and as long as your nose and mouth are open, air will enter the lungs, and that's the process that we described last time we met as negative pressure breathing. It relies on the creation of a vacuum, which is what we mean when we say negative pressure. Now, notice that this is initiated in the brainstem, and it's thought that one form of sleep apnea, which is the type of sleep apnea that results from brainstem malfunction, is thought to contribute to a disease called SIDS, where the child will simply stop breathing in their sleep and die. And we don't really understand why it is that the brainstem malfunctions in that fashion, but there's a lot of research in that area that's looking at trying to understand malfunctions in the brainstem and correct them. And here what you're looking at is just a diagram showing you the diaphragm and the lungs and the mechanics of negative pressure breathing. So you can see here that the lungs rest with their base on top of the diaphragm and their apex just above the collarbone. And when the diaphragm contracts, it'll flatten, and that's what creates the vacuum around the lungs. At the same time, when we try to sort of up the ante when we breathe, for instance, when we exert ourselves, one of the ways we do that is using accessory muscles. And one set of those accessory muscles are the intercostal muscles, which elevate and expand the rib cage. And you've probably noticed that when you expend a lot of energy and breathe really hard, your chest goes in and out at a great rate and with a great volume. You can practice it now if you want to do a set of forced breathing exercises. Breathe in deeply and notice how your chest expands more fully than when you breathe normally. And again, that's to meet the oxygen demand of the body under increased activity. Remember that the reason that we have to breathe is to get oxygen into the blood, and what the blood does is delivers it to metabolically active tissue. The metabolically active tissue can then use that oxygen in order to generate enough ATP, remember that that's biological gas in the tank, in order to run the body. Remember that in the presence of oxygen, we can make 36 ATP per glucose molecule, but without oxygen, we make a pathetic 2, and that's not enough really to run the body for any significant length of time, hence the need to breathe, the need for oxygen. The ease of ventilation is called compliance. Basically, the more compliant something is, the more stretchy it is. High compliance requires little effort to expand the lungs. Low compliance is more difficult to expand the lungs. Basically what happens is that the lungs can become less stretchy, more leathery, and as a result, even with maximal contraction of the diaphragm and the intercostals, it gets difficult to cause those lungs to expand in volume and bring in that air. Emphysema can also affect lung compliance, and you might ask how, and the answer is it creates scar tissue inside the lungs that does a couple of things. One, it causes the lungs to become less compliant, less stretchy, and in addition to that, it damages the alveoli and takes away from surface area that's necessary for gas exchange. Bronchioles become damaged and wider. This increases compliance. It makes it easier for air to get into the lungs. However, these same changes make it much more difficult to exhale, and this leads to air getting trapped in the chest. The external intercostal muscles also help by moving the ribs up and outward to assist in expanding and contracting the volume of the thoracic cavity and increasing the amount of air that we can move in and out of the lungs per unit time. Okay, so exhalation is essentially a reverse of the processes that we associate with inhalation. It's a passive act caused by the return of the diaphragm to its resting state. So remember, with the diaphragm rests, it assumes a dome-like position, and what that does for the thoracic cavity is reduces its volume. This decreases the space in the thoracic cavity. It increases the pressure above atmospheric, and if your nose and mouth are open, the air will exit out of the nose and the mouth. While we can consciously influence breathing rate, our breathing rate is ultimately controlled by the amount of CO2 in the blood. If carbon dioxide levels rise in the blood, it means that you're not ventilating or blowing off enough CO2, and as a result, the medulla oblongata will send signals to the respiratory muscles to increase the rate and the depth of your breathing. And the idea here is to not let the CO2 accumulate in the interstitial fluid and in the blood, because that can lead to metabolic acidosis. And what that'll do is interfere with membrane potential and disrupt the ability of the nervous system to function properly, and also the musculoskeletal system, especially when we're talking here about the neuromuscular junction, the sending of the chemical signal from the end of the axon to the membrane of the muscle cell in order to initiate the electrical events that eventually lead to muscle shortening. And that all, again, depends on ion movement. And if we mess up ion movement as a result of introducing extra hydrogen cations, those are protons, what will happen is it will interfere with that electrical signal. So it's very important that we not let CO2 accumulate, the waste gas, the deadly waste gas. Okay, during increased activity we need more oxygen. The accessory muscles are used to help pull up the rib cage and make the thoracic cavity even larger, and so we can bring in more air with each breath. The accessory muscles include the scalenes in the neck, the sternocleidomastoid. Remember that that's the muscle that attaches to the mastoid process at the posterior base of the ear, the sternum in the anterior aspect, and the clavicle, the collarbone. Also the pectoralis major, the large muscles in your chest, and the pectoralis minor. And the pectoralis minor muscles, remember, lie just beneath the pectoralis major. And so, again, this combined action of these accessory muscles serve to further expand the rib cage. While exhalation is usually passive, there are times when exhalation may need to be forced, such as during certain disease states. Accessory muscles of exhalation assist in the more forceful and active exhalation by increasing abdominal pressure, and the main accessory muscles of exhalation are the abdominals that push up the diaphragm and the back muscles that pull down and compress the thoracic cage. And we can get a look at those here. So you can see here the diaphragm, and beneath it you see all of the abdominal muscles that can assist: the rectus abdominis, the external and internal obliques, and the transverse abdominis. And the way they do this is they compress the abdominal pelvic contents. This helps to push up on the diaphragm, decrease the volume of the thoracic cavity, and assist with exhalation. Let's talk about some diseases of the respiratory system. The common cold is caused by a virus called the rhinovirus. The signs and symptoms are airway congestion, a cough, and sore throat. The diagnosis for this is a history and physical. The treatments include pain meds, bed rest, and hydration, and also proper nutrition. Feed a cold, starve a fever was the way they always taught it to me when I was a youngster. Remember that there actually is a med on the market that can cure or shorten the duration of the common cold, and that's zinc. Remember that zinc interferes with the ability of the rhinovirus to attach to the mucous membranes, and thus reduces the number of tissues that could potentially be infected. You can get zinc as a lozenge, or if you're lucky enough to have some of the zinc nasal swabs, those are very effective at reducing the duration of the common cold. Laryngitis is, again, a viral or bacterial infection. It can also result from the overuse of the voice. Basically, it's an inflammation of the larynx, the voice box. Signs and symptoms are dysphonia, an inability to properly speak, sore throat, and trouble swallowing. Diagnosis is history and physical, and the treatment is to rest the voice. Tonsillitis can be either viral or bacterial or both. The signs and symptoms are sore throat, swollen tonsils, and dysphagia, trouble swallowing. The diagnostic tests are a history and physical, and the treatment is antibiotic if it's bacterial in nature, Antivirals, perhaps if it's viral in nature, or surgery if the inflammation leads to necrosis and the tissue begins to die and becomes a source of infection rather than a source of defense against infection. And this is the classic example of the child whose tonsils need to be resected as a result of massive infection. And so they take the tonsils out, and then they always tell the child, well, after the surgery, you can have all the ice cream you can eat. And of course, the cool trick there is that you can't eat any ice cream because your throat is too sore to swallow it. Okay, flu. Let's be aware of the flu because there's a flu epidemic rushing through the United States right now. It's viral in origin. Signs and symptoms are fever, cough, and body and headaches, so soreness throughout the body. We do a history and a physical for a diagnosis. And the treatments are rest, fluids, pain meds, and treating the symptoms. We could use antivirals. It's just that there aren't that many good antivirals on the market, especially when we talk about the flu virus. And the reason for that, again, is that the flu virus and viruses in general work by hijacking your cell's own machinery in order to reproduce. And so in order to generate an effective antiviral, we often have to attack the biosynthetic processes that exist in our own tissues and our own cells, and that may end up eventually causing our own tissues to get sick or weak. And it also puts a huge tax on the liver because these compounds, as with antibiotics, as with most meds, have to be cleared by the liver or else they'll build up to toxic levels and they could then produce other disease symptoms. Pneumonia is viral, bacterial or fungal in origin. The signs and symptoms are a productive cough, meaning that you cough up sputum or phlegm that's infused with dying tissue and bacteria or whatever the infective agent happens to be. You also feel chest pain, weakness, malaise, and dyspnea. Remember that dyspnea is labored breathing. Malaise is essentially a loss of energy, and this is because your body's busy fighting the infection and you don't have a lot of energy left over to do anything else but lie in bed. The diagnostic tests include imaging, blood work, and sputum culture, and the treatments are antibiotics if we confirm that it's a bacterial infection. If not, obviously we may use antibiotics to prevent secondary infection, but if in most cases we assume that it's a viral pneumonia, then essentially we just provide for bed rest and let the body take its own defensive action. Okay, tuberculosis. It's caused by bacteria. The signs and symptoms may be an asymptomatic secondary cough. It could be blood tinged. You might see fever. You might see night sweats, and you could experience weight loss. We diagnose this with imaging, tuberculin skin test, and a sputum test, and the treatments are antibiotic agents. Now, when we say a tuberculin test, that's the classic test where you introduce a tuberculin antigen subcutaneously, and if you are harboring the virus, the likelihood that you have recruited now B and T cells to fight the infection is very high, and so what will happen in the tuberculin test is that you'll see an inflammatory response, a pronounced inflammatory response. If this isn't the case, you'll see virtually no response in the skin test. Okay, we're going to touch on a few diseases here. We'll talk about
Allergic rhinitis occurs when people who are allergic to airborne particles of dust, dander, or the pollens of certain seasonal plants have been exposed to these substances. Symptoms include coughing, headache, sneezing, and itching nose, mouth, and eyes. When an allergen is inhaled by a person with a sensitized immune system, it triggers antibody production. These antibodies bind to cells that contain histamine. When the antibodies are stimulated by pollen and dust, histamines are released. This causes itching, swelling, and mucus production. Symptoms vary in severity from person to person. Very sensitive individuals can experience hives or other rashes. Heredity and environmental exposures may contribute to a predisposition to allergies. The history of the person's symptoms is important in diagnosing allergic rhinitis, including whether the symptoms vary according to time of day or the season, exposure to pets or other allergens, and diet changes. Allergy testing may reveal the specific allergens the person is reacting to. Skin testing, the most common method, includes intradermal scratch patch tests. The goal of treatment is to reduce allergy symptoms caused by the inflammation of affected tissues. The best treatment is to avoid what causes allergic symptoms in the first place, or to take steps to reduce exposure to allergens. Medications include over-the-counter and prescription antihistamines, nasal corticosteroid sprays, and decongestants. Allergy shots, also known as immunotherapy, are occasionally recommended if the allergen cannot be avoided and if symptoms are hard to control.
Cystic fibrosis is a genetic disease, and the young people who have this disease exhibit the production of very thick, tenacious secretions throughout their body. In the GI tract, these thick, tenacious secretions result in the inability to absorb food substances from the GI tract. As a result, there's a characteristic failure to thrive and a malabsorption associated with the disease. In the lungs, these thick, tenacious secretions harbor certain bacteria that eventually become resistant to the antibiotics that the physicians use to fight them. Once these bacteria become resistant to the antibiotics, the lungs are destroyed and the patients can no longer breathe.
When I get up in the morning, right before breakfast, I have to take 8 or 9 enzymes which help digest the food and break it down. And I also have to take, with that, 2 antibiotics which help keep my lungs clear, and like 3 vitamins just to help me, stay strong or whatnot. And then I have to do 3 inhalers which clear up my airway so I can, am able to breathe.
Our understanding of this disease is very different today than it was 10 years ago, 5 years ago, or even 2 years ago. As a result of our investments in understanding the basic defect, we can now begin to treat the causes of cystic fibrosis. Physicians until now have always had to treat the symptoms of CF, the malabsorption, the pancreatic problems, and the chronic lung disease that's associated with this disease. But now, when we have the ability to treat the basic defect, we can look into the eyes of the young people with this disease and say, we are clearly going to make a difference.
Asthma is an inflammatory disease of the bronchi characterized by wheezing, dyspnea, and a feeling of constriction in the chest.
Each person with asthma has an exaggerated sensitivity in the lungs' airways or bronchial tubes. When this sensitivity to such things as the common cold, cigarette smoke, dust, or animal dander is triggered, the muscles around the airways contract. This narrows the airways and makes it hard to get air in and out. The wheezing that is often heard is usually the air being exhaled through the narrowed tubes.
Most people with asthma have periodic wheezing attacks separated by symptom-free periods. Some asthmatics have chronic shortness of breath with episodes of increased shortness of breath. Other asthmatics may have cough as their predominant symptom. Asthma attacks can last minutes to days and can become dangerous if the airflow becomes severely restricted.
Common triggers of asthma include colds and flu, irritants in the air like cigarette smoke or perfume, allergens or things you're allergic to like animal dander from cats or dogs, exercise without pre-treatment or warm-up, changes in weather, especially cold weather, also emotions such as laughing, crying, or getting angry, or any stressful situation may play a role in making an asthma attack more severe.
Many people with asthma have an individual or family history of allergies, such as hay fever or eczema. Treatment is aimed at avoiding known allergens and respiratory irritants, and controlling symptoms and airway inflammation through medication. There are two basic types of medication for the treatment of asthma.
One type of medicine, called a bronchodilator, is commonly used to provide relief from symptoms after an episode has started. Another type of medicine, anti-inflammatory medicine, is often prescribed to help prevent asthma flare-ups. They come in different forms and brand names. Cromolyn and Edocramil and corticosteroids are used as anti-inflammatories.
Emphysema and chronic bronchitis are chronic obstructive pulmonary diseases, disorders mainly of middle-aged or older patients, in which tissues react to smoking, other pollutants, or repeated infections. In chronic bronchitis, the bronchial lining is inflamed, excess mucus forms, and cells are unable to clear away accumulations because the cilia are damaged. In emphysema, the walls of the alveoli break down, reducing the surface area. The lungs lose elasticity, and stale air laden with carbon dioxide is trapped in the lungs. Care for all respiratory conditions is similar. Do not withhold oxygen. The need outweighs the risk of administration. You need not diagnose a condition to provide effective treatment. Constantly monitor the patient. If breathing becomes inadequate, assist respiration through artificial ventilation and obtain medical direction.
Sleep is an essential part of our lives. When we don't get enough sleep, we don't feel rested during the day. We feel irritable and cranky. Recent research by the National Sleep Foundation showed that millions of people in the United States are sleep deprived.
What does your husband say about your breathing at night? Is it regular, or is he...
He says I pause when I sleep, and then I move, and then I start breathing again.
Loud snoring accompanied by long pauses in breathing during sleep is known as sleep apnea, a sleeping disorder. People who have sleep apnea are often urged to see a doctor by an exhausted spouse who is kept awake each night by the loud snoring. And it's important to treat sleep apnea because of long-term health risks.
Sleep apnea is a condition that's present in about 4% of middle-aged men and 2% of middle-aged women, can be seen in children, and can be seen in the elderly.
Sleep apnea is the most common problem seen in sleep centers today. And Dr. Atkins reports there is growing evidence that sleep apnea has a significant effect on people with hypertension, congestive heart failure, and stroke. So treatment of sleep apnea can go a long way to help patients with these cardiovascular diseases.
In addition, if you're tired during the day and you're tired at a critical time, such as while driving a car, the adverse consequences of falling asleep at the wrong time can be disastrous to you and other people on the road.
Talk about some treatments for respiratory distress. Let's talk about oxygen. Oxygen, of course, is a vital component of the air we breathe. We need it, again, to produce adequate ATP in our body's tissues in order to drive life processes. Oxygen can be administered as a medical treatment for respiratory and cardiovascular diseases. The benefits of this type of therapy is it reduces the work associated with breathing, it increases the oxygen content of the blood, and it reduces the work of the heart. Now, you can't just give infinite amounts of oxygen in order to relieve respiratory distress symptoms. Pure oxygen is actually toxic if it's inhaled for too long. The lungs will actually scar. So usually when you're taking oxygen, you're not taking the pure gas, you're taking a gas mixture, usually spiked with nitrogen in close to atmospheric concentrations. Other drugs that affect the respiratory system, there are drugs that narrow the airway. These are bronchoconstrictors, and there are drugs that dilate the airway, and these are bronchodilators. Now, we would want to use a bronchodilator if the upper respiratory tract were occluded, say in an asthmatic attack. They will provide rapid relief during the times of acute airway narrowing. Inhaled steroids can also be used as an anti-inflammatory for long-term treatment of airway inflammation. And this can sometimes result in airway narrowing. Again, with inflammation, you always associate edema, swelling, and as a result, occlusion of the upper airway. These treatments are preferred over systemic steroids because they have less systemic side effects. Again, long-term use of systemic steroids can suppress the immune system and leave you open for infection, and that's something we want to avoid at all costs. Okay, we'll touch on smoking and smoking cessation. Let's talk a little bit about surfactant. Surfactant is an exudate that's created inside the lungs that's a biological detergent that keeps the lungs from clinging together and not re-expanding after an exhalation. Essentially, the biological components in the surfactant overcome the surface tension in the water, and as a result, it's very easy for the lungs to expand with each inhalation after each exhalation. We administer artificial surfactant to premature infants who don't have sufficient surfactant in their lungs in order for the respiratory system to operate properly. We instill it into the lungs, and this allows time for the infant's lungs to complete development and develop their own surfactant. Systemic antibiotics can also be used for treating bacterial lung infections, and inhaled insulin can be used to treat diabetes. And so here you can see some of the different drugs that we administer for different types of respiratory diseases, where they act and what they do. Okay, so let's look at each of these. Antitussives suppress cough. Okay, again, remember that when you cough or you sneeze, if you don't cover your mouth, those moisture droplets that are imbibed with the pathogen can hang in the air for up to 15 minutes. And so this is one of the reasons why during the colder months, when you're inside more often, you're more likely to get a cold or the flu, simply because the likelihood of you coming into contact with a sick person is much higher. Okay, mast cell stabilizers inhibit histamine release. Histamine is one of the chemical components that initiates the inflammatory response. And in general, the inflammatory response is a good thing because it's usually initiated in response to an infection, the invasion of a pathogen. It is characterized by redness, swelling, pain, and edema. And these are all designed to bring blood to the area. In the blood are contained the emergency medtechs of the body, the white blood cells, and they act to destroy the pathogen and also alert the immune system to the presence of a pathogen so that we can rally the B and T lymphocytes to select for and generate large numbers of cells specifically designed to fight that pathogen. But in allergic responses, it is actually not beneficial because you're not actually responding in that case to a pathogen. You're generally responding to a particulate or a trigger that may not actually present a disease hazard to the body. Mucolytics loosen mucus, essentially allowing you to clear the mucus that's often laden with pathogen and dying tissue from the lungs more easily, allows you to more easily breathe. Glucocorticoids are inflammation suppressors, so very often they are used as inhaled steroids. And expectorants produce thinner mucus, so they act similar to mucolytics. In fact, you often get meds that are a combination of a mucolytic and an expectorant in order to clear that junk out of the lower and upper respiratory tract. And then finally, beta-adrenergic agonists dilate the bronchi, and this allows more air to get into the lungs with each breath, reduces airway resistance, makes it easier for you to breathe, and allows you to exchange more effectively oxygen for CO2. Okay, so that brings us to the end of this particular chapter. That's the end of chapter 13. You will be responsible for all this content on the midterm, so listen, take notes, and if you have any questions, shoot me an email or find me during office hours. Remember, that's Friday from 4 to 8 up in the library. And good luck, and I will see you in class.